We're back again. We're going to look at Chapter 2 in your Biophysical Agents book, and we're going to be talking about tissue response, pain, and the way your body perceives these things. So the patient's perspective is, I keep hearing this phrase, no pain, no gain. Is that really necessary? Well, there is a certain amount of discomfort, and we should be teaching the patient how to control the pain and get through those difficult times. So we need to make sure that we are teaching good pain remedy methods and controlling what we're doing in the clinic. We should not be overzealous and be one of those therapists that is constantly causing a 12 out of 10 to all of our patients. Here are your learning outcomes. And we're going to dive on into the different types of pain, the causes of pain, experience of pain. But before we do that, we need to describe pain. So what is pain? Do your best to define the term pain. So what is pain? We can look in our book on page 14 and we can see the actual description of pain. And pain is just an unpleasant sensory or emotional experience associated with an actual or potential tissue damage. So pain is an unpleasant sensation that we have. It can be an emotional effect. Sometimes, like if we're afraid that something's going to hurt, it's going to hurt more, even though the physical pain may not be to the same amplitude. We feel like it is because we're frightened, we're scared, but sometimes it is actual a physical pain that's causing it. So there's different types of pain. So let's look at this chart. So there's different types of pain. There is acute pain, there's chronic pain, and there's referred pain. So acute is going to be a recent onset. A chronic pain we're going to talk about, it's going to be at least been the pain for 3 months. And referred pain can the patient gets real confused when we talk about referred pain. Sometimes, like if you have organ pain, you may have jaw pain, or you may have arm pain, or you may have back pain, but it's really not where you're feeling the pain that is the source of the pain. So we need to make sure we're drilling down, we're finding the source of the pain. So low backs are often that way. If you have maybe a nerve entrapment or a pinched disc at say the L2, the lateral thigh is where the patient's going to perceive the pain. And so when you start treating the patient and you go to the back and their pain is in their thigh, they're going to think that you're kind of crackers, to be honest. So you're going to need to be able to explain to them why you're treating their low back when their pain is in their thigh. And so we'll dive in and get a better concept of that. But there are different descriptions of pain, and they're going to help like drill down what's causing the pain. So if it's burning or sharp, the first thing I need to be thinking about is nerve pain. If it's radiating, I'm going to think about nerve pain because those are describing factors of nerve pain. If it's dull or if it's aching, that may be a muscle strain or something like that. Then you have radiating pain. So that's usually a pinched nerve, or throbbing could be a couple of different things. Sometimes the first thing I think of is infection. A lot of times infection causes a throbbing pain, especially at night. So those are all describing factors. So when we're writing our note, we need to be listing what type of pain it is. We have an acute, burning, stabbing, hot sensation that's radiating into the left foot. Then the next thing you need to make sure that you discuss in your note is the frequency of the pain. So you're going to have to ask the patient, and you may have to direct them. You know, is there a certain time of the day? Is it in the morning? Is it in the evening? Is it once a day? Is it every day? Is it all day? Is it after you do a certain event? Like when I get up and I walk for the first 15 minutes out of the bed, that's very predictable. I can put my finger on what's causing it. So we need to make sure that we're listing the frequency of the pain. Is it predictable? Is it unpredictable? Is it with certain motions? So these are all ways that we're going to help find our source of the pain plus document the source of the pain and document what the patient is telling us. So then, and where is the location of the pain? So the back, the neck, the leg, the ankle, the shoulder. So if I have a patient that comes to me and they tell me that for the last week, when they get up out of bed first thing in the morning and they step on their foot and try to walk to the bathroom, that they're having very sharp stabbing pains, and they last for 15 minutes, I'm going to know that they have an acute type of pain. Probably plantar fasciitis is the first thing I'm going to think of, because it starts to relieve itself. It only happens first thing in the morning, so I'm going to document all these things. Mrs. Smith reports the therapy with acute pain, describes pain as sharp, ripping, stabbing type pain for the first 15 minutes as she walks. This is the only time that she feels this pain in the day or after she sits for a while. And so I'm going to just write that in my note. So let's talk about the different types of pain. So we have acute pain. And so acute pain is going to be really easily to define, because they're going to be able to put their finger right on, okay, my heel hurts just anterior to my calcaneus. I have a really tender area. This is where my pain's at. And if I don't step on my foot, so I'm able to relieve and locate that pain, then I know it's an acute pain. It's going to be, an acute pain is always going to come from an infection, an injury, or an internal disease. Very easily to diagnose because it's very localized, very easily to distinguish the factors that contribute to the pain. So that is acute pain. But chronic pain is that pain that has lasted longer than 3 months for sure. But another real telltale factor of chronic pain is they're not really able to tell you what caused the pain, or it's not well defined. It's in a generalized area. It's been hurting for months or even years. And to be honest, a lot of times the pain from a chronic pain is not even caused from an actual physical injury. It's actually a result of the chronic pain triangle, and we're just going into this vicious cycle, and we'll talk about what that is in just a second. They have let me just say protective guarding is what causes the chronic pain. So maybe you have low back pain and then you have muscle guarding. And so all right, so let's take a back patient. And so the back patient is saying that it hurts to step on their right leg. So they start hopping on their left leg. They're trying to stay off of that right leg. So what's happened is they're no longer in the right posture. They may be leaning to one side. Now they're hopping on a leg. So our back pain has caused muscle guarding. It hurts. So we're going to hop off that side. So we created a dysfunction. So now we have gotten the back more out of a line. And so that that misalignment that's happening is feeding into the pain. So then the pain is going to cause more muscle guarding. That the increased muscle guarding is going to lead to dysfunction, and this is just a triangle of pain. Now, chronic pain will lead to long-term loss of function. So let's look at your book on page 16, and we're going to talk about the different types of mechanisms that can create chronic pain. So the first one is the mechanical, and that was what I was just describing to you as a nerve entrapment syndrome. The example in the book is carpal tunnel. It could be low back. It could be anywhere where the nerve is becoming entrapped. And so so mechanically, there are two structures that are pinching or narrowing the space where the nerve goes, and it causes chronic pain. But then we have chemical pain. or chemical mechanics, or chemical mechanism. Sorry about that. So chemical mechanism. So there's a chemical irritation from in an injured area. And so what's happening here is the body has some kind of trauma, inflammation, maybe ischemia, which means the loss of blood flow to that area. And so these substances increases the sensitivity of the nociceptor. And you remember the nociceptor is your pain receptor. And so what happens is it releases another chemical, and so whenever that chemical is released and is introduced into the tissue, then there's a loop of inflammation that's happening. So this loop causes inflammation, and so then the inflammation causes more pain, and then the pain causes more inflammation, and so it's a chemical reaction happening here. This chemical that's being released is prostaglandin, and so it is the enzyme that creates more inflammation. Another mechanism that may cause chronic pain is regeneration. As a nerve regenerates from surgery, trauma, or just an injury, there is a point where that nerve becomes more hypersensitive. And as they become more hypersensitive, there is more transmissions to those A delta and C fibers. And so what it really feels like to a patient is it feels like little bitty ants are stinging and prickling. And that's a normal response, but that there is, it's not normal if it doesn't stop over a point in time. So if, say my arm that has the incision on it, at first, as it's healing, it should kind of go through a stage where the nerves are regenerating, and eventually those little prickly stinging feelings won't be there. But sometimes your body gets stuck in a cycle and it just keeps that hypersensitivity. So we may have to do some desensitization training. Then there are reflexes is another mechanism. And so this is what we often call muscle guarding. And so there is a normal response for your body to go into a protective phase and to protect you from further injury. But sometimes your body gets caught into this muscle guarding. And so it's a result of ischemia, which means the loss of good blood flow, loss of good oxygenation to the area, or maybe even a nerve compression. If this is allowed to continue over time, you can have trophic changes. And what those trophic changes can do is they can form little fibrous tissue formations. And these may be like a trigger point that you'll eventually get. And so they're very hypersensitive areas for patients. And the last type of mechanism is inhibitory failure. And we won't go into this a whole lot, but these are when there are signals that are not active at the dorsal horn. And so whenever you have a multiple sclerosis or MS, there is a demyelinating factor that happens to the nerve, and so they start to have this chronic pain that happens with them. So if you look at your book on page 17, the 3 criteria for chronic pain is the cause is uncertain or not correctable. Medical treatment has been ineffective. So they have already been to other people, other physicians or other clinicians or maybe specialists of sorts, and they've just really been ineffective. And then pain has persisted longer than 3 months. So if you want to know if there is chronic pain, it has to meet those requirements. And if you have a patient with chronic pain, a team approach is the best way to proceed, because there's a lot of factors going on with this patient. So these patients, we're going to have to teach them how to rest from whatever activity seems to aggravate the pain and then build up their musculature that supports the area. We'll really look at body mechanics. We'll do posture education. We'll make sure we're doing stretching, strengthening to that area. We're going to have to do cardiovascular, maybe even relaxation techniques. If they're returning to a job, we're going to have to do work conditioning or hardening. And then the use of physical agents such as ice and heat, and then your TENS units to try to ward off and correct that chronic pain and decrease the chronic pain triangle. And chronic pain goes past physical ailments. It goes to emotional and mental. A lot of your chronically pain people, they really go into depression, and so we need to also be able to be their positive environment for their mental health also. Let's talk about referred pain just real quickly. And so referred pain is pain that arises from the deep body structures but are felt in another distant site, and this is called referred pain. And so we talked about that it could be visceral pain, which is your organ pain. It could be nerve fiber pains. And so a lot of times you're going to find these pains by knowing your dermatomes, your sclerotomes, and your myotomes. And so we'll talk about what your dermatomes and myotomes are, especially as we go on. But dermatomes is where on your body does a nerve, if it's referring pain, show up. It's going to be in a distant area of the body. And your myotones are going to be where is there possible a pain coming from a muscular structure, and it's referred to a different area of the body. And I'll show you some charts of dermatomes and myotomes soon. So let's look at this next chart. And so here is just side-by-side views of acute pain and chronic pain. So acute pain is going to be lasting for a relatively short time, very sudden. If you see that sudden or recent onset, we're going to know that it's acute pain. If it's lasting longer than 12 weeks or 3 months, the same thing, it's going to possibly be chronic pain. So we're going to start looking in that direction. Acute pain usually is a response to something very specific, like they know when the injury happened. Like 2 weeks ago, I was doing this and my pain started. Chronic pain is very different. They have no apparent cause. They can't remember when it happened. It's just kind of arose sometime in their past. So sudden onset versus 3 months or longer. Acute is very specific, whereas chronic is no apparent cause. Acute is a way of your body is trying to tell you that there's something wrong. So if I cut my foot, then my body's trying to tell me that even though my eyes can't see the bottom of my foot, I need to look at the bottom of my foot. So there is something very specific in the way your body is trying to tell you that there is something going on. Chronic pain, if caused by a trigger, the pain usually outlasts the original cause. So whatever the original cause was, we may not even have that problem anymore, but we changed our posture, we changed our mechanics, and now we have this pain that's happening because we changed something in the way our body structure is either aligned or the method we perform something. Acute pain occurs for a very specific amount of time. If I cut the bottom of my foot, I'm not going to have pain in that area 12 months later. But chronic pain is often ongoing, no specific amount of time that it will last. It can last for a lifetime if we don't find the source of the cause and source of the pain and correct it. So there's different ways that we can manage pain. These different ways of management is pharmacology, and pharmacology is just medication, and there's a couple of different kinds. Then there's thermal agents, and we'll be doing that this week, and that's your hot and cold agents. And then lastly is your electrotherapeutic devices, and that's what you'll be learning all summer long between mine and Tommy's classes. So let's talk about pharmacology real quick. So pharmacology is just your OTC, which means your over-the-counter medicines. So are you taking Tylenol, Advil, Aleve? Those are all OTC medicines. Then you have your anesthetics, which means there is no sensation where the medicine is administered. So it could be a topical ointment, it could be possibly injectable, and so you just don't have any sensation when that medicine is injected. So if you have you've heard patients going for injections in their low back or whatever, that's an anesthetic. They're trying to give you some relief to allow the inflammation and to stop that chronic pain triangle. And then analgesia. We can look at different ways to reduce the painful stimuli. There are narcotics and there are non-narcotics. And we'll talk about what the differences are. Narcotics are derived from opium, so they're very addictive, and so they need to be very limited, and we need to schedule these medicines as far apart as possible while still managing the pain. And so they're used to relieve severe pain. So right after surgery, the doctor will give your patient some narcotics, but that's not going to be long-term use. 10 years ago, you got on narcotic and you could stay on it as long as you wanted to. But the problem was people were becoming addicted to drugs, addicted to prescriptive pain medicines. And so they've really had to reevaluate the way they use these. So the way they work is, or the different kinds of medicines that you may see is codeine and morphine. Or that they come in different name brands. Your Norco, your Loratab, those are different types of codeines. And then your morphines is like your fentanyls and different opium, your oxycodones. Those are morphines. And so they have to be written with a prescription by the doctor, but they're highly, highly restrictive now. You'll hear them called Schedule II drugs, and they're super regulated and super tracked. So we want them only on those right from the beginning. They have to have them for a short period of time, so we do need them to take them, but we only need to take them to control the pain. Non-narcotics are going to affect the hypothalamus, and so this is your aspirins and your NSAIDs. That's your non-steroidal different drugs. But the only problem with NSAIDs, and that's your ibuprofens, the only problems with that is they have a lot of GI issues. So if you have someone that has GI issues or is complaining about bleeding or just stomach irritation, they are not really good for those patients. But one thing to note is NSAIDs disrupts the inflammatory process, which can be good or can be bad, because there's a certain amount of inflammatory process that should happen so that you heal. So that's a problem. But that is our pharmacology that we're going to cover. All right, so thermal agents are going to be your hot and your cold. Those are the things that we're going to cover this week, and how those can help decrease muscle spasms, stiffness, inflammation that's going on. And then your last type of pain management is your e-stims and modalities, and that's another thing that we'll do. But so basically it affects through stimulating the peripheral nerve system, or the CNS. So all right, so here are the dermatones and myotones I told you that we would look at. So your dermatones are, if let's look at, say a patient has thumb pain and they don't have any hand injury, and they're complaining that it's sharp and it's stinging and it's prickling. So I'm going to immediately think that it's a nerve. And so what I'm going to do is I'm going to start looking at the C6 spine to see the cervical spine nerve root 6 to see if there's any kind of entrapment or impingement, and if so, that's going to be where I'm going to work. I'm not going to work on the thumb because the thumb is not injured, it's just being referred. Same way with your myotones. So if I have deltoid pain, I possibly need to be looking at C5 so that it's rising over in another area. So that is what a dermatome and a myotone looks like. So it may not necessarily follow a specific spinal nerve pattern. There may be a jump in the location, and so you may have to really kind of drill down on that patient to find out where the pain is from. But if they have like an active trigger point, it's going to follow a very characteristic pattern for that muscle. So if you can find that trigger point and release that trigger point, that patient's pain is going to release. And we'll actually find trigger points in each other because there are many. Okay, so let's talk about different pain assessments. If you look in your book on page, I think it's page 20. Let me look. Yeah, page 20, there are different types of assessments, and so we're going to look at those real quick. This picture to the right is your McGill-Melzack pain questionnaire, and if you notice that it's really in depth, like it's wanting to know what kind of medicines you're taking, how often do you take them, you know, what's the hours in between, but then it gets real particular, like do you have a quivering pain, do you have a pulsing pain, does it shoot or jump or flash? And these are really good words you can use in your notes. Are they prickling or sharp or stabbing? Are they just miserable or are they intense? So that is a very descriptive type of pain scale. So you can really narrow it down. And on the little body that you have, you mark on your patient's paperwork where is their pain. You know, if they're having forearm pain, you put an X in that area. And then it even talks about like, can you sleep? I sleep good, or I sleep fitful, which means I'm shifting around, or I just can't sleep at all. Like it's the worst. You know, is it affecting how much you eat? Like some people really cut down on the amount they eat when they're in pain. So that is the McGill-Melzack pain questionnaire. But then we have this visual pain scale. So some patients, especially children, you can't ask them 1 through 10. They don't understand their numbers well enough. So you definitely would use a visual analog scale for your children that are your patients, you know. Where does it hurt, or how does it hurt? Like point to the patient, the face that you feel like you are. And it kind of gives a description, but you will find out a lot of patients need this same scale because they can't quite understand. They don't know what an 80 is. And so this gives them a better description. But a lot of times you'll use a 0 to 10, and I'll say that 0 is no pain whatsoever, and 10 is excruciating pain. I need to go to the emergency room. And so then I kind of help them kind of figure that out. So usually 1 to 3 is mild pain, 4 to 6 is moderate pain, and then 7 through 10 is pretty severe pain that they're in. So we talked about your body reacts in 3 specific ways. They're going to, if you have an injury, you're going to have muscle guarding. You're going to notice that you have some kind of edema forming in that area. And then last thing is we're going to have some release of an endogenous pain chemical receptors. So there's a few different kinds that we have, and I actually prostaglandin that I said earlier that is released. So there are cytokines, histamines, bradykins, prostaglandins, and leukotrienes. So those are all different types of endogenous pain chemical receptors that your body's going to release immediately when there's inflammation. So we are going to look at those 5 cardinal signs of inflammation. If you didn't learn them in the spring, you definitely need to learn them in the summer. So they are pain. So it just hurts. It could have warmth to the skin. There's going to be some sort of heat in the skin or in that area. There will be redness possibly, so it's going to be red or pinked. And then there's going to be swelling or edema. And then lastly, usually because of the pain, the inflammation, the swelling, you're not going to be able to have as much function. So if I injure my elbow and it swells up, I immediately lose range of motion. So those are your 5 cardinal signs. We talked about this and we drew this off in the spring, just the way the pain receptors, the A delta, and the C fibers, the different ones. The A delta are your larger fibers. They're really discriminative to your touch. They're myelinated. That's your sharp, prickly type muscle fibers. And then your C is your unmyelinated. You're slow. You're poorly localized, maybe burning. So that just gives you so we won't go over this again because we talked about this summer. This spring. There is a great little YouTube video if you would like to watch that. That will help you on your test. We talked about the gate control theory. This was when we bit our tongue, but we waved our hand at the same time, and it changed the pain. All right, so the phases of healing, inflammation is 1 to 10 days. Proliferation phase is 3 to 20. The wound is very tender, very fragile. And then remodeling is 21 days forward. So we went over that. If you need any refreshers, you can come see me. And we'll talk about these different questions in class. One thing I did want to go over and touch real quick is your phantom limb pain, and that is what happens if you look on page 24. It's in your book. Phantom limb pain is a pain that a patient reports that arises from a body part that has been amputated. It's very specific to an amputation patient. The sensation can be anything from paresis or crushing, throbbing, burning sensation. They'll often say that their toe itches and their toe is no longer there. So if you tell them to scratch the end of their residual limb, it usually relieves it. The nerves that were once connected to the toe are still intact in the upper quadrants of the leg, and so there's still sensations that the body's trying to tell the limb that is no longer there. The exact cause is very unclear. They don't really understand it, but it appears to come from the spinal cord and brain. But it's a real phenomenal, and there's a couple of things you'll learn about, like mirror therapy, that helps a lot of times. But the pain is real, and so they have to treat the pain. They do find out that patients that have an amputation where the nerve is stretched and then clipped has less phantom pains than patients that they're just cut off at the end of the residual limb. And so some advancements have increased with that.